Welcome back, everybody. In this third video, I want to discuss some academic articles that investigate gaps in data collection due to things like recruitment, inequitable access to healthcare, and gender disparities in some clinical trials. With these case studies in mind, I also want to discuss some additional ethical frameworks for you to consider. So as I mentioned, we have some case studies. So these are just some articles that I think are helpful in understanding and thinking about this idea of what gets counted counts, as well as just overall representation in things like clinical trials, and also thinking about geography and access to healthcare. So in the first article, it's a study by Vitali and colleagues. The authors show how women and the elderly are often underrepresented in randomized clinical trials for cardiovascular disease, even though these diseases highly affect both women and the elderly. So the treatment in these clinical trials were mostly done on middle-aged white men, yet the elderly do have a higher incidence of disease-related morbidities and adverse drug-related events. And not to mention, women do differ in presentation, clinical manifestations, and outcomes compared to men. So it's just a very helpful look in sort of who gets included, or at least in this example of clinical trials, sort of how women and the elderly were underrepresented. So in addition to this, the second article that I want to talk about focuses on Black men in prostate cancer clinical trials. So they looked at the diversity enrollment in about 60 prostate cancer clinical trials. So these are the ones that had race-related information, and they found that over 96% of those participants were white males. Yet in the United States, less than 60% of prostate cancer cases occur in non-Hispanic white men, and roughly 22% of cases occur in non-Hispanic Black men. So the article shows that African-American men enrolled in prostate cancer has actually decreased over time. So in 1995, it was about 11.3%, and it is just under 3% now in 2014. So the difference between 95 and 2014, we can see sort of a pretty large jump or decrease in African-American participation. So the overall conclusions of this paper show that trial participants continue to be majority white despite the known racial disparities in prostate cancer clinical outcomes. With this in mind, I also want to mention a study by Clark et al., who found that racial and ethnic minorities were often left out of the clinical trial process. And they focused on some critical barriers to inclusion. So some of those barriers include things like mistrust, lack of understanding of the values of clinical trials, fear or stigma of participating, as well as things like communication styles of investigators and staff. In addition, they mentioned things like lack of comfort with the clinical trial process, or even a lack of information about the clinical trial process and sort of its benefits and how it works overall. And lastly, they mention things like time and resource constraints that are associated with participation in the clinical trial process. So lastly, I want to mention the Kaplan and Friesen article, which talks about including or the inclusion of diverse populations in clinical research will lead to better, more robust data, things like greater equity, and hopefully fewer health disparities when they are included. So in addition to things like recruitment and sort of who does participate in clinical trials, I also want to mention geography, so rural and remote locations. So the first article by Beckenmeyer et al., they did qualitative interviews across Alaska, Ohio, Oregon, and Washington with individuals expected to use population data for analysis or decision-making in rural communities. So this is specifically with rural public health leaders. And they found several things, including a challenge in accessing or using data from these communities to address health disparities, a greater need for things like data training. They also mentioned things like data quality issues, as well as limited data. So in terms of we know that data is used to make decision making, but when we don't have data on things like rural communities, it's hard to go through that process. And lastly, the second article talked about data collection in rural communities, especially the Finger Lake region. So that is in upstate New York. So they did qualitative interviews with 45 older adults in rural upstate New York. And the research question focused on health promotion behaviors and involved older rural women with heart failure who had been referred to by primary care physicians or nurse practitioners. So data was collected during visits to these women's homes. And the authors mentioned several barriers to both gaining data as well as this idea of access to healthcare. And they mentioned for the majority of folks that participated, they lived 25 to 50 miles from major roads, often in remote areas. They had limited access to clinics and clinicians. And they referred to this idea of triple jeopardy, where someone is living in a rural area and also has either advanced age or poor economic status and overall relative isolation from healthcare services. So in both of these articles, the authors discuss the difficulties of data collection in rural communities, yet, ideally, including these populations in our data collection would lead to better health outcomes. So with that said, a lot of the articles just discussed are relevant to things like health disparities and the idea of social justice. So health disparities are systematic, plausible, avoidable health differences adversely affecting socially disadvantaged groups. Health disparities include differences that occur by gender, race, or ethnicity, education or outcome, disability, living in rural localities, or sexual orientation. And health disparities need to be a social justice concern because they are shaped by social context, and as such should be put into the broader context of social justice and human rights. So there are some tenets for health equity. In thinking of sort of the frameworks that we can think about, this is, I think, a helpful one. And the tenets for health equity include all people should be valued equally. Health has a particular value for individuals because it is essential to an individual's well-being and ability to participate fully in the workforce and a democratic society. Every person should be able to achieve his or her optimal health status without distinction based on race or ethnic group, skin color, religion, language, or nationality. And health differences adversely affecting socially disadvantaged groups are particularly unacceptable because ill health can be an obstacle to overcoming social disadvantage. And lastly, health equity is the value underlying a commitment to reduce and ultimately eliminate health disparities. So the idea of number one, knowing what health disparities are, and then putting them into the framework of some tenets are very helpful, especially when we think about those case studies. So I do want to talk a little bit more about ethical frameworks. So in our first class, or our first module, we talked about some ethical tenets related to autonomy, beneficence, non-malfeasance, and justice. So just as an example, when we talk about autonomy, this is the idea that a person has a right to participate, a right to decline, and they will be free from coercion. So beneficence, this idea that it's going to be the welfare of research participants would be protected. And it can contributions to the well-being of others. So this overall benefit in participating. And now malfeasance, some considerations are limiting or eliminating disturbing, uncomfortable, or negative impact. And justice, so the benefit inclusion of diverse populations, solidarity and reciprocity, and health inequalities versus equity. So those are some ethical principles that were previously discussed. And I think they're very helpful in thinking about those considerations and how they can be incorporated into our frameworks when we think about data collection. So we can have and ask ourselves a few questions, especially as it relates to data. So in thinking about data collection, can the research and our research question be done using publicly available or pre-existing data? So this idea of non-malfeasance by reusing existing data. Is the proposed research likely to have significant public health or biomedical value? So the idea of beneficence. Does the research require sensitive data, or can we gain insights by not collecting sensitive data? So the idea of autonomy. Are there greater or minimal risk of harm arising from privacy breaches? Can these be reduced to minimal? So kind of harking back to the idea of non-malfeasance. Is consent given, and is transparency being practiced? So, connecting to autonomy. Is the sample representative of the community? So in thinking about the clinical trials and sort of excluding either Black men or women from clinical trials, is it actually representative? And if it's not, what can we do about it? And lastly, will the community understudy benefit from the research? So does it kind of go back to the community and sort of raise that community up and give some insights to it? So the idea of beneficence, justice, and solidarity. So that's just a few questions that I think you can consider when we talk about not only the ethical principles, but how it can be applied to the research process and data collection. So in addition to these ethical principles, I want to mention that there's something called community-based participatory research, where the community members have a larger role in the research process. So just a little bit about this. It's where researchers and community stakeholders engage as equal partners in all steps of the research process with the goal of educating, improving practice, or bringing about social change. It questions the power relationships that are inherently embedded, this idea of traditional Western knowledge production, and acknowledges the legitimacy of experimental knowledge. Experiential. And then it's also useful when working with populations that experience marginalization, because it supports the establishment of respectful relationships with these groups and the sharing of control over individuals and groups' health and social conditions. So there is a much larger sort of community component and sort of participant component, and sort of giving power to your participants, as opposed to, the researcher kind of always being in charge. So I think it's a very helpful framework in thinking about and working with community members. And lastly, I do want to mention non-Western Indigenous perspectives. This perspective will talk about the disconnect between Western methodologies and Indigenous research, and the idea of Indigenous statistics operate as unequal power relations and are defined for and by non-Indigenous producers and consumers. So a lot of what we consider Indigenous statistics don't actually come from Indigenous people. And it also mentions that it's not aligned with Western perspectives of things like difference, disparity, disadvantage, dysfunction, and deprivation in health. So a lot of times Western perspectives will focus on sort of the negative, and sometimes the Indigenous perspective does not align well with those sort of Western perspectives. So all of the articles here are linked in the slides. So I definitely encourage you to check them out and then use some of these frameworks when we are thinking about data collection. All right, and then please join me in our last video, where we'll be talking about some additional considerations. All right, see you in the next video.